Let me thank AOS for this wonderful opportunity, Dr. Maipal, Namartha, and the entire team for this wonderful initiative of International AOS webinar. Hats off to people like Dr. David Chang, who's staying back so late in the night, sir. Thank you very much, sir. And also Boris, who's always with us for all the conferences as well. I'm going to talk to you about the rock hard cataracts, the top 10 tips. You can see this rock hard cataract, it's like a piece of granite inside the eye. Okay, and if you try to do the Phaco, then you can end up in various problems in these rock hard cataracts. What are the problems you can end up? There's a challenge to Phaco surgeons, difficult to crack the nucleus because of leathery attachments, thin posterior capsule, large nucleus, poor or no cortical cushion, increased incidence of corneal edema and postoperative corneal decompensation, increased incidence of PCR and nucleus drop as well. Number one, what is the number one tip? Good preoperative assessment is very, very important. Do a specular microscopy, make sure the cornea is not sick, and grading of the nucleus is also very important. Pupillary dilatation is also a very critical component of the surgery, and age of the patient is also important. As the patients go older, the zonules are likely to be weaker. Combine the technology with the technique in super hard cataracts. Technology like what you have, it's available to everybody, Stellaris, Ocel, or Centurion, or whatever, or Ellipse. And technique is vertical chop using a sharp chopper. And you can have the various missions here, and even missions like Apaswami, the TurboWit, or the Robo is working very well. If you do the conventional divide and conquer, the stop and chop, it not only takes a longer time, but you end up in a burn like this, a corneal burn. You know the consequences of a corneal burn: irregular astigmatism and wound gaping, infection, even endophthalmitis as well. You can have a corneal edema like this, which can take a long time to clear. The corneal edema sometimes may not clear up at all, and the corneal edema can be associated with a high incidence of cystoid macular edema and something like a TAS in the anterior segment fibrin reaction. And the incidence of cystoid macular edema with the corneal edema like this is as high as about 25%. And you can see something like a fibrin reaction. Number two is, I do these patients under Peribulbar or Parabulbar anesthesia because I want to make the patient comfortable. I'm also comfortable because I'm expecting a little longer surgery for these patients. So this is again a very important thing. Don't do these patients under topical anesthesia unless you are really very experienced. Rexis always use trypan blue. Very important. Make a Rexis which is slightly larger, about 5.5 millimeter will be in the critical size as far as this thing is concerned, because I need that space to chop. Especially these cataracts are very big, 8 to 10 millimeter in dia, and very thick as well, 5 millimeter to 6 millimeter. And that is the reason why I need to go a little larger as far as the Rexis is concerned. Why trypan blue? Because I want to know exactly where my Rexis margin is while I'm chopping as well. Be careful in doing a hydrodissection. Don't be aggressive. You can have an underlying posterior polar component. Also, if you have a small Rexis and a huge cataract, you can end up in a problem like this. You can see as soon as my assistant puts the viscoelastic on the cornea, the nucleus disappears, probably because of hydro rupture, which has occurred in this case, which I didn't notice. Again, use a high Phaco power for trenching. The normal misconception used to use less Phaco power. If you use less Phaco power, every time you trench, what happens is you push the nucleus. And every time you push the nucleus, there is a stress on the zonules. And zonules are already weak in these hard brown cataracts as well. Adequate tip exposure is very important. Again, because you want to go inside the nucleus as much as possible before you have produce a good vacuum seal. And I go bevel down. You can go bevel down or bevel sideways. This is a sharp chopper which a device made by Apaswami. I don't have any financial interest. It's got 1.5, 1.752 millimeter, and you can see this is 1.5 millimeter, 1.75 millimeter, and a 2 millimeter which is used for the brown cataracts. The 2 millimeter is also multi-purpose. You can stab somebody in the abdomen as well if you want to. Okay, and this is a tangential chop. You can see this is a tangential chop. This you can do in a little grade 2, grade 3 cataracts, but not cataract or rubra, cataract Niagara. But you can see use that in a high myopes when they have anterior chamber depth as well. This is an horizontal chop wherein you go under the Rexis and come from the equator. Again, you can see here in these brown cataracts, what happens is need a good cortical cushion. So horizontal chop may be a little tricky because there's no cortical cushion, there's nucleus and more nucleus, and the possibility of rupturing the zonules or damaging the zonules or even producing a PC tear as well. This is a quick chop express which are device. You can see here I have using a Stellaris machine. whatever machine you are comfortable. I'm using a Rexis, which is about 5 to 5.5 millimeter in dia with a trypan blue. And then these are the parameters I use on a Stellaris PC machine, 60% Phaco power, vacuum on a seeing 450 600 on a linear, duty cycle of about 40%, and you can see pulse rate of about 90 pulses per second. More importantly, you can see here I'm chopping. The first chop is very, very important. Direct the chop directly vertically down and making sure that you go all the way down and do the lateral separation. Being a sharp chopper, it opens up the posterior nuclear plate with great ease. You need to see the posterior capsule through and through when you're doing this chop. Then you attack each of these halves. Each of these halves and make it into multiple pieces. Make it into multiple pieces. So I'm doing the bevel down. I always do the bevel down. You can do bevel sideways because or the bevel up or whatever you're comfortable. Bevel down, I do it because I'm a little more comfortable because the vacuum seal occurs a little more faster with the bevel down. You can see here again, I'm chopping that cataract into smaller pieces and I'm just going on the dual linear which is available on the Stellaris machine and going to the yaw position and automatically the lenses start coming into the Phaco handpiece as well. With another patient, you can see the cataract or rubra again. You can see I'm doing a small trench. The small trench just to make sure that I dip the Phaco tip into the body of the nucleus. Don't go above, don't go below. Go into the middle of the nucleus. That is the body of the nucleus. You can see how difficult it is to separate the posterior nuclear plate. The posterior nuclear plate is what is most leathery, and it's important that you go there and making sure that your left hand works much more than the right hand. Making sure that you catch that piece on the right side and then do the lateral separation and the vertical movement as well. This is a vertical chop wherein you chop right under direct visualization, right in front of the rexis margin, which makes very, very life easy. Then you make sure that the posterior nuclear plate is divided, and these patients is very difficult to do the hydrodelineation. There is no nucleus or epinucleus. There's only nucleus and there's no epinucleus. You can do something like a epinucleus or hydrodelineation in situ. It's just to make sure that the epinucleus protection is there while the nucleus is being removed. Just to make sure that you can see the cataract of Niagara, I'm just gradually increasing the grade of the cataract here. Cataract of Niagara, I make a little deeper trench in this particular case, gentle rotation, then chop. You can see here how I'm holding that piece. I'm trying to use the left hand more, doing the lateral separation. The chopper works like real magic, opening up the posterior nuclear plate without any problem at all. And these are the parameters you can use. Only thing is you need to use a high Phaco parameters. You can use either Ozil, ellipse, or the hyperpulse, which is there on the Stellaris machine. Again, you can see the what you call the micropulse or the hyperpulse or the Ozil technology, which makes life, because the amount of Phaco energy which is there, which is there in the anterior chamber, which is very, very less. It's a part of the cold Phaco technology, which you use to prevent the chatter of the lens as well. So during the off time, there is a cooling of the tip and also the sucking of the nucleus into this thing. Again, you can see here the hyperpulse or micropulse makes it very, very easy for the cataract to be removed very nicely. This is another step which I would like to give as a take-home message. Introduce dispersive viscoelastic. I prefer viscode. I don't have financial interest into the anterior chamber now and then, because to prevent sometimes the pieces come and touch the corneal endothelium and can have a white cornea. So take time off and maybe now and then inject viscode into the anterior chamber to make sure that the corneal endothelium is well protected and you can have a clear cornea irrespective of the density of the cataract on day one. These are the various viscoelastic which is available. You can see these are the various corneas. You can see pristine wound, clear cornea on day one, despite the fact that the cataracts are very, very hard. If you have access to CATALYS or FEMTO Phaco, for that matter, this makes life very, very easy because the rexis is done, whatever size you want, the pre-cut is there, and you can see here, I'm just opening up the posterior nuclear plate. The very fact that the gas bubbles are coming up shows that the entire cut has gone through into the posterior nuclear plate as well, and this makes actually life easy. And the amount of Phaco energy, as I told in the morning, also the amount of Phaco energy is only 30 to 40% of my regular cataracts as well. Again, white cataracts, making the rexis is very, very difficult. I do the FEMTO. So good preoperative assessment, peribulbar, parabulbar anesthesia, rexis, trypan blue, minimal hydrodissection, high Phaco power for trenching, exposing the tip, vertical chopping or a karate chopping, and hyperpulse or the cold Phaco technology for the removing the thing and viscode through the side port now and then, right to the endothelium. If you have access to FEMTO, then this is the quick chop express which makes life easy, effective, and enjoyable both for the patient as well as for the surgeon. Thank you very much, AOS, for the wonderful opportunity again.